Hello everyone. Today we are going to discuss about the management of difficult airway. So we have this 54-year-old male patient diagnosed with case of recurrent carcinoma of right buccal mucosa. He was an adjuvant chemotherapy, now admitted for 7 cycle of immunotherapy. Patient was shifted to endoscopy room for PEG tube insertion, and during procedure, patient became desaturated and had cardiac arrest. So code blue was announced in the endoscopy room. So already two attempts of the laryngoscopic guided intubation. So this was that patient. As you can see, his airway was severely compromised, and because there was no access in the neck, the phona was also not possible. So still we had done already two attempts of the laryngoscopic guided intubation, and intubation was done with the help of video laryngoscopy. The grade of intubation was CL grade 3, and after intubating, the patient was shifted to ICU. So challenges in this airway, grade of the intubation was CL grade 3. It was difficult to ventilate and phona was not possible. A case of 44-year-old female presented with the left hemiplegia, motor aphasia, left homonymous lateral hemianopia after 6 weeks of partial stage excision of chordoma. CT MRI showed the chordoma size of 70, 50, and 54 nasopharyngeal mass at the level of cleviers, that is C1 and C2, meningioma 27 by 27 by 15 extradural frontal lobe mass with right MC infarct. Histopathology showed left lymph node biopsy, which was suggestive of chordoma. On day 2, in ICU, patient had stridor leading to tachypnea and desaturation, and she underwent emergency tracheostomy. So difficult intubation are common in intensive care unit, emergency department, and pre-hospital setting, with incidence ranging being between 8% to 13%. Possible causes are compromised cardiorespiratory physiology, risk of aspiration, presence of specific factor related to environment, and inadequately trained operators render tracheal intubation in ICU more likely to be associated with complication compared to that in the operating room. So challenges during tracheal intubation in ICU, ICU related factors like infrastructure, lack of space around the patient, poor access to the patient's head, poor lighting, trained help may not be available. Then equipment, airway devices such as fiber optic bronchoscope, supraglottic airway, video laryngoscope may not be readily available in the ICU. Then regarding timing, emergency intubation may be required at any time in a day or night. Then regarding anatomical challenge, airway assessment, difficult or impossible due to lack of time or patient being uncooperative. Then challenging anatomy, maxillofacial trauma, cervical spine injury, airway injuries, burns, and retropharyngeal abscess. Then risk of aspiration is because of full stomach, gastroparesis associated with critical illness, patient not fasted requiring emergency intubation, inefficient pre-oxygenation due to presence of shunt, VQ mismatch from underlying illness, and reduced functional residual capacity. Then regarding physiological challenges, there is always risk of rapid desaturation because of lack of physiological reserve, often lead to rapid hypoxemia, hemodynamic instability due to critical illness or use of drugs used to facilitate intubation. Then operator factors like training, limited airway training and poor airway management skills. Inexperienced junior doctor may be performing intubation alone, and stress. Then predicting difficult intubation in ICU, the Macocha score has been recently developed to identify patients with potentially difficult airway in the ICU. The score not only consider patient-related anatomical difficulty but also physiological factor and operator expense. The Macocha score includes Malampatti score 3 or 4. A total point given to that are 5. Then obstructive sleep apnea, total points 2. Reduced cervical spine motility, total point 1. Mouth opening less than 3, total point 1. Coma, 1. Saturation less than 80%, total point has allotted to this point is 1. And then non-anesthesiologist, then if the person is non-anesthesiologist, then the total point that has been given is 1. The score thus has maximum 12 points with 0 points predicting an easy intubation and 12 point predicting a very difficult one. Other physiological factor need to consider subsequently hypotension, hypoxemia, lack of pre-oxygenation, obesity, age more than 75 years are relevant risk factors for cardiac arrest. Right ventricular dysfunction is also increasingly appreciated risk factor as perturbations in the gas exchanges, then acid-base status, intrathoracic pressure may all lead to cardiovascular collapse. Then special consideration during tracheal intubation in intensive care unit. Presence of two operators are needed, one experience in airway management. The presence of two operators during ICU intubation with one being experienced in airway management. Then in addition to the two operator present during intubation, it is recommended to call for additional help at the earliest when the first difficulty in airway management is encountered. It is also recommended to call for additional help when the final attempt at rescue mask ventilation fails and emergency cricothyrotomy is planned. Then regarding pre-oxygenation and peri-intubation oxygen in intensive care unit, oxygen saturation is the most common, desaturation is the most common complication occurring during intubation in ICU, and it is the most common reason for aborting intubation attempts. Therefore, proper pre-oxygenation is important to prolong the time to desaturation during intubation, and it increases the chance of the first attempt success at intubation. So pre-oxygenation can be given by NIV and high-flow nasal cannula. Regarding NIV, 3 minutes of pre-oxygenation using non-invasive positive pressure ventilation delivered by ICU ventilator using face mask. Then the mask is more effective at reducing desaturation than face mask with bag and reservoir. Then regarding high flow nasal cannula, oxygen delivered at 70 liter per minute through device capable of providing heated humidified oxygen. Then Miguel Mantones et al. Showed that high flow nasal cannula oxygen is administered at flow rate of 60 liter per minute for pre-oxygenation and continued during intubation, reduce the risk of desaturation from 14% to 2% compared with NRBM pre-oxygenation. After pre-oxygenation with NIPPV, the addition of high-flow nasal cannula oxygen during attempt at tracheal intubation significantly reduces the severity of the desaturation. So now the next question is which one is better, whether we should pre-oxygenate with NIV or high-flow nasal cannula. So when comparing the efficiency of high-flow nasal oxygen with NIV, the severity of the baseline hypoxemia must be considered. And the Florali 2 trial reported that 24% of patients pre-oxygenated with NIV develop saturation of less than 80% versus 35% who were pre-oxygenated with high-flow nasal oxygenation. So the conclusion of Florali 2 trial was NIV in comparison to high-flow nasal cannula alone helps to decrease the episode of severe hypoxemia during intubation procedure of ICU patient with hypoxemic respiratory failure requiring mechanical ventilation. The Optinive trial explored the combination of high-flow nasal oxygenation and NIV in 50 patients with mean PF ratio of 122 and found that patients receiving the combination intervention maintained the higher saturation during intubation than those in the NIV only. Then the next concept is apneic oxygenation. Apneic oxygenation provides through high-flow nasal cannula during laryngoscope may decreases desaturation during intubation and may lead to higher first attempt success without hypoxemia. The use of apneic oxygenation by simple nasal cannula at 15 liters per minute to prolong the duration of safe apnea after administration of neuromuscular blockage have been advocated in the ED. However, recent randomized trial did not show benefit of apneic oxygenation during tracheal intubation in critically ill patient, possibly because the effectiveness of apneic oxygenation in critically ill patient may be limited by the presence of illness causing physiological shunt. Recently, the addition of supplemental oxygen through nasal cannula in the presence of mask leak has been shown to improve end-tidal O2 during pre-oxygenation. Then next point is critical position. Some of the difficult intubation can be occurred in normal airway in challenging circumstances. So optimizing position is the key. The angle of jaw should be the level of top of the chest with ability to tilt the head back. So this is the head position for the tracheal intubation as shown into the uh, C, that is a sniffing position. So we need to optimize the oral axis, pharyngeal axis and laryngeal axis as had shown into the figure C. Now, if RAM position is useful, if the patient is obese, so as we can see into the figure 7, the RAM position is all about the alignment of axis of airway. The mastoid process should be the level with the top of the chest. If not, then the airway appears anterior during the laryngoscopy. If you can use the RAM made up of the stake of the line to optimally position the morbidly obese patient into sniffing position for intubation. So make sure the patient still can tilt the head back. Then these are the some more critical situation where the optimization of the position is the challenge. Like in the figure 9, we can see the CPR is ongoing and this operator is intubating the arrested patient, and due to the difficult position, he cannot intubate. So as we can see in the position P, so giving the so how to intubate in this situation. So we need to give the operator a stationary target and stop the CPR while intubating, but make sure there should not be delay in the CPR for more than 10 seconds. Then in the figure 10, when the patient is lying on the ground during intubation, how are we supposed to intubate this patient? So 2 points. The position is awkward and relies solely on the forearm on forearm strength to lift, and the weight of the head pulls you off the balance. So positioning the head between the knees and leaning back allows you to use the strength of your back and shoulder to lift. Then this is the video of the ramping. Patient positioning system's rapid airway management positioner, also known as the PPS ramp, is an the ramp is a safe patient. Next is hemodynamic stabilization. Hypotension after intubation is reported in nearly half of the intubated patient in ICU, with cardiovascular collapse occurring in 30%. So hemodynamic instability is the independent predictor of the death following intubation. So peri-intubation hemodynamic instability has been shown to increase ICU stay and hospital mortality. This study highlight the importance of fluid resuscitation in critically ill patients along with pre-oxygenation to improve the safety of emergency intubations. In addition, preparedness and the prompt treatment of post-intubation hypotension with vasopressors and further fluid therapy are although adequate fluid resuscitation can help prevent post-intubation hypotension. Proper selection of the drug for intubation is equally important. Then, regarding the selection of pharmacological agent for tracheal intubation, drugs such as benzodiazepine, propofol, thiopental may be used in reduced doses. However, they decrease the systemic vascular resistance, reduces myocardial depression, and may cause precipitous fall in the blood pressure. So these are the drugs which can be used for rapid sequence intubation. So first one is etomidate. The advantage of this drug, it has a good hemodynamic stability. The disadvantage, it can produce corticoadrenal insufficiency. Then ketamine, it will provide the more hemodynamic stability. It has the property of bronchodilation. It has analgesic effect, rapid onset of action, like 45 to 60 seconds. And then adverse effect is hallucinations. Then the propofol, it can also be used as bronchodilator, rapid onset of action within the 15 to 45 seconds. It has anti-epileptic property and better suppression of upper airway reflexes. Then the contraindication, disadvantage are it will cause the hemodynamic compromise. Then the in neuromuscular blockers, so we have two agents like succinylcholine and rocuronium. Succinylcholine has the advantage of rapid onset of action that is within 45 to 60 seconds. The disadvantage, there is always risk of hyperkalemia, anaphylactic risk, and increasing oxygen consumption. Then rocuronium has no risk of hyperkalemia. Antidote that can be used used to antagonize the effect of the rocuronium is sugammadex. It has a less rapid onset of action that is 45 to 90 seconds, and it has a risk anaphylactic risk is always there. So drugs such as etomidate and ketamine are preferred in comparison in ICU. Although there are concerns about transient adrenal insufficiency with etomidate, especially in septic patients, there is no convincing evidence of harm. Ketamine, due to sympathomimetic effect, help to maintain the blood pressure during intubation. When compared to etomidate, there was no difference in the rate of complication. Ketamine may cause hypertension, tachycardia, increased airway secretion, raised intracranial and intraocular pressure. Unless contraindicated, it should be preferred induction agent for endotracheal intubation. Other agents such as opioid, dexmedetomidine, lignocaine can be used as an adjunct to blunt sympathetic response to laryngoscopy. So this is the meta-analysis which compared the ketamine versus etomidate in induction as an induction agent for tracheal intubation in critically ill adults. So it revealed the etomidate versus the conclusion of this trial was ketamine versus etomidate among critically ill adults requiring tracheal intubation. It showed the induction with ketamine is associated with reduced risk of mortality. Now the next is role of neuromuscular agent. The use of neuromuscular blocking agent not only improves the laryngoscopic rate of view, but also overall intubating condition. The use of neuromuscular blocking agent has been shown to improve first attempt intubation success with both rapid and delayed sequence intubation, irrespective of choice of induction agent or route of administration use. Suxamethonium has been conventionally used neuromuscular blocking agent of choice unless contraindicated due to its fast action, facilitating early intubation without the need of ventilation. However, rocuronium at dose of 1.2 mg per kg has comparable speed of action and intubating condition to suxamethonium. Although now regarding device selection, although most widely used in OR, video laryngoscopy has been shown to increase first attempt success and improve glottic visualization during intubation in ICU, ED, and pre-hospital setting, even in patients with predicted difficult airway. The meta-analysis by De Jong et al. Comparing direct laryngoscopy with video laryngoscopy for tracheal intubation in ICU showed that first attempt success was twice as much when video laryngoscopy was used. So this is the recently published trial in NEGM, that is device trial, which compared video versus direct laryngoscopy for tracheal intubation in critically ill adult. And the conclusion of this trial was the use of video laryngoscopy resulted in higher incidence of successful intubation. Now, the effect of use of endotracheal tube and stillate versus endotracheal intubation on first attempt intubation success. And the conclusion of this was that it was a randomized trial involving critically ill adult undergoing tracheal intubation. The use of stillate for tracheal intubation was safe and resulted in significantly high first attempt intubation success than the use of tracheal tube alone. So this is the video demonstrating the use of video lens. So this is the airway management algorithm, and according to this algorithm, what they are saying is first we have to assess the uh, airway for the difficulty of intubation, and we can assess this difficulty with the help of Macocha score. If the Macocha score is 3, less than 3, then it depends on then the whether we should use for the direct laryngoscopy or video laryngoscopy is depend upon the choice of the physician. But if the Macocha score is more than or equal to 3, then it's better that to increase the intubation success, it's better to go for the video laryngoscopy. So 10 tips to improve the first attempt intubation success using video laryngoscopy. Training of operator in this remediation center, then the training of operator with patient. At least 15 intubation should be performed in patient using video laryngoscopy. Use of the predefined airway management algorithm. Then careful assessment of the difficulty of intubation before intubation using Macocha score. Then choice of single video laryngoscopy device, adequate pre-oxygenation for limiting hypoxia and rush during procedure, careful suctioning of the secretions, rapid sequence intubation with the use of neuromuscular blocker, use of stillate or bougie for unchanneled video laryngoscopes to allow easier intubation of the glottis. Then regarding rapid sequence induction, most of the ICU patients are considered to have full stomach, and securing the airway with rapid sequence intubation seems logical. So either suxamethonium and rocuronium may be used for neuromuscular blockage. Application of the cricoid pressure may make laryngoscopic view unfavorable. In such a situation, cricoid pressure should be partially or completely released to improve laryngoscopic view and later reappear. Gentle mask ventilation while applying cricoid pressure before tracheal intubation can prolong the time to desaturation and may be useful in patients with poor respiratory reserve and sepsis. A second generation supraglottic airway device offers greater protection against aspiration as compared to the first generation devices and should be inserted if tracheal intubation fails during rapid sequence induction. Insertion of supraglottic airway device insertion may become difficult if required pressure is applied and thus should be released during insertion. Now, 7 P's of rapid sequence intubation like preparation, pre-oxygenation, pre-treatment, paralysis with sedation, positioning, placement of the tube, and post-intubation management. Confirmation of tracheal tube. The studies showed that failure to use capnography contributed to 17 death and brain damage in the ICU. So, esophageal intubation and accidental tube displacement accounted for 82% of events leading to death and brain damage. This report strongly recommended the use of capnography for confirmation of tracheal intubation in all critically ill patients, irrespective of location. Now, regarding human factors and training. Intubation in ICU is required at any time in day or night or may often be performed by less experienced practitioners. So, in addition, considering the altered physiology of critically ill patient, lesser time to desaturation, and higher risk of complication, these intubations may lead to very stressful situation which can compromise the performance of operator sometimes. Thus, airway management training should be integral part of the training of any specialty which deals with critically ill patients. And the use of simulation-based training will help to enhance both technical and non-technical skill and improve preparedness for this highly stressful situation. The use of algorithmic approach and the intubation bundle may further improve performance. The intubation bundles a structured way of improving process of patient care outcome using small, straightforward, evidence-based practices, which when performed collectively and reliably have proved to improve patient outcome. Adherence to protocol resulted in significantly lesser life-threatening complications such as severe hypoxemia, severe hypotension, and cardiac arrest, and also mild to moderate complication compared to conventional strategy. So this bundle has 10 components, which include the presence of two operators, fluid loading with 500 ml saline, preparations of long-term sedation, pre-oxygenation for 3 minutes and non-invasive ventilation, then 100% oxygenation, pressure support ventilation between the 5 to 15 to obtain the expiratory tidal volume between 6 and 8 ml per kg, and a positive end expiratory pressure of 5 centimeter of water in case of acute respiratory failure in pre-intubation period. Rapid sequence induction is performed using required pressure with either ketamine or etomidate for induction and suxamethonium or etomidate for neuromuscular blockage. Post-intubation component include immediate confirmation of tube placement using capnography, using norepinephrine if diastolic blood pressure remains low, initiation of long-term sedation, and the use of protective lung ventilation. Now, the stepwise approach for the management of tracheal intubation in ICU. So, ADA proposes the stepwise approach for management of tracheal intubation. It is important to remember that while following any step in the algorithm, if oxygen saturation is not maintained or starts rapidly falling, or if bradycardia develops, then one can bypass one or more steps and proceed to rescue ventilation or even emergency tracheostomy. So the step one is pre-oxygenation and induction of anesthesia. During intubation, the presence of minimum 2 persons is required, out of which one should be experienced in airway management. So pre-oxygenation should be done using non-invasive ventilation with pressure support ventilation level between 5 and 15 centimeter of water to obtain expiratory tidal volume between 6 and 8 ml per kg and PEEP of 5. High flow nasal cannula with 70 liter per minute of oxygen flow should be used. Pre-intubation fluid loading with 500 ml of saline should be given in the absence of cardiogenic pulmonary edema. The patient should be anesthetized using ketamine or etomidate and neuromuscular blockage provided with succinylcholine and rocuron. The intermittent positive pressure ventilation may be performed using bag valve masks with reservoir bag using external PEEP valve set at 5 to 10 centimeter of water. If PEEP if available, or intermittent positive pressure ventilation using ventilator maintaining a cricoid pressure through. Cricoid pressure should be given but may be partially or completely released if ventilation is inadequate. Then regarding step 2, laryngoscopy and tracheal intubation. Mask ventilation is successful. Proceed with tracheal intubation using direct or video laryngoscopy. Nasal oxygenation using O2 flow of 15 liters per minute or high flow nasal cannula O2 should be continued. Do not exert more than 2 attempts at intubation and repeat attempt only if saturation is more than or equal to 90. Mask ventilation should be performed between the attempts. Optimize position, use the external laryngeal manipulation, partially or completely release the required pressure to optimize laryngoscopic view if required, the use of bougie and stellate if required. Between the attempts at intubation, consider changing the device or technique rather than repeating the same technique. Then maintain the depth of anesthesia throughout the intubation attempt. If mask ventilation is not possible, a single attempt at intubation could be made, provided saturation is more than 90. After intubation, confirm proper attitude position using capnography along with clinical methods. Then step 3 is insertion of supraglottic airway device to maintain oxygenation. If 2 attempts at intubation fails or after a single attempt at intubation following unsuccessful mask ventilation fails, then insert supraglottic airway device and ventilate to maintain oxygenation. Not more than 2 attempts should be made to insert supraglottic airway device and only if saturation is more than or equal to 95%. Nasal oxygenation using O2 flow of 15 liters per minute and high flow nasal cannula O2 should be continued during supraglottic airway device insertion. Perform mask ventilation between the 2 attempts. Consider using different type and size of supraglottic airway device during second attempt. Maintain depth of anesthesia throughout the insertion attempt. Once supraglottic airway device insertion is successful and oxygenation is maintained, consider performing percutaneous and surgical tracheostomy for further airway management. Intubation through supraglottic airway device may be considered, but only under vision using flexible fiber optic bronchoscopy. Intubation should not be attempted blindly through supraglottic airway device if bronchoscope and other expertise to use it are unavailable. Then rescue face mask ventilation. If ventilation through supraglottic airway device is also failed, then continue nasal oxygenation using O2 flow of 15 liters per minute and high flow nasal cannula. Ensure complete neuromuscular blockage and repeat muscle relaxant if required. Give one final attempt at face mask ventilation using optimal technique and actions. If rescue face mask ventilation is unsuccessful, proceed with percutaneous and surgical tracheostomy. However, if rescue face mask ventilation is unsuccessful, there is complete ventilation failure. Continue nasal oxygenation using oxygen flow at 15 liters per minute or high flow nasal cannula and call for additional help. Immediately start performing emergency cricothyrotomy before the patient desaturated further. Then the last step is emergency cricothyrotomy. Perform emergency cricothyrotomy using needle and surgical cricothyrotomy based on familiarity and the availability of the equipment. If needle cricothyrotomy is performed, maintain oxygenation using pressure regulated jet ventilation and use tracheostomy if planned until tracheostomy is planned. If wide bore cannula cricothyrotomy set has been used or ET tube has been passed through the front of neck, continue ventilation manually or using ventilator circuit. So this is the video demonstrating the cricothyrotomy. So this is the again the summary of the EDA guideline for tracheal intubation in ICU. So first is two persons are required, one with experienced staff and the so out of the 2%, one has to be experienced. Then optimize, then the adequately pre-oxygenate the patient with the use of NIV or high flow nasal cannula, or you can use the combination of it. Then use the proper according to the background history of the patient and hemodynamics, preferably ketamine. For neuromuscular blocking agent, we can use either succinylcholine or rocuronium. Then give the appropriate cricoid pressure and the positive airway pressure with a reservoir bag with optimal peak of 5 to 10. Then if our face mask ventilation is successful, then we can attempt the then we can give the two attempts of laryngeal endotracheal intubation. Make sure between those two attempts, maintain the adequate oxygenation and the depth of anesthesia. And between these two attempts, continue the oxygen flow at 15 liter per minute. And with the help of high flow nasal cannula, also we can give the oxygen. But if the face mask ventilation is unsuccessful, then give only the single attempt at tracheal intubation. And if the intubation is failed, then insert the supraglottic airway device to maintain the oxygenation. So between this also, continue the nasal oxygenation using O2 flow at 15 liter per minute or using high flow nasal cannula. Preferably while using supraglottic airway device, preferably use second generation supraglottic airway device. In this also we can give the maximum two attempts. Then consider changing the size and type of the supraglottic airway device. Maintain proper oxygenation and depth of anesthesia between the change of attempt. If the attempt of supraglottic airway device is successful, then consider either percutaneous or surgical tracheostomy, or we can intubate directly through the supraglottic airway device using the fiber optic bronchoscope only. So if there is a failed ventilation through supraglottic airway device, then we can consider rescue face mask ventilation. Continue nasal oxygenation using O2 flow at 15 liter per minute or high flow nasal oxygen can ensure the neuromuscular blockage. And first attempt at face mask ventilation using optimal technique and action. If it is if this attempt is successful, then we can go for the surgical or percutaneous tracheostomy. But if this face mask attempt is unsuccessful, then there is a complete ventilation failure, and we need to call for the additional help. If there is a complete ventilation failure, then go for the emergency cricotherapy. So during this, continue nasal oxygenation at 15 liter per minute or with the help of high flow nasal cannula and perform one of the technique like surgical cricothyrotomy, whiteboard cannula cricothyrotomy, and needle cricothyrotomy. And if this is successful, then convert it to the tracheostomy at earliest. Now this is again the update of Montepillar intubation protocol. So in pre-intubation, two operators are needed. Fluid loading with the help of 500 ml of the fluid. Then the preparation for the long-term intubation. Then for pre-oxygenation, consider upright position. Pre-oxygenation we can give at least for 3 minutes using NIV in case of hypoxemic respiratory failure, or uh, we can use the method of the apneic oxygenation. And we can also use the combination of high flow nasal cannula and NIV. Then use If we are encountering the difficult airway, then first attempt of the intubation should be with the video laryngoscopy. Then go for the rapid sequence induction with the help of for this we can use the intermediate ketamine and neuromuscular blocking agents like succinylcholine and rocuronium. Then give the proper ventilation if patient's oxygenation level is less than 90. Then for assessment of the correct position of the tube, we can use the capnograph. If after intubation, if the patient is hypotensive, use the appropriate vasopressor to maintain the systolic blood pressure more than 90. Start early long-term sedation, low airway pressure ventilation at beginning, like tidal volume at 6 to 8 ml per kg, PEEP of less than 5, FR 200, and try to maintain the plateau pressure less than 30. Also give the recruitment maneuver and the cuff pressure between the 25 to 30. Then summary of this talk is check every position for difficult intubation. Not every patient is in distress, need intubation. Teamwork and communication are essential. If airway looks difficult, consider awake intubation. People, place things, gather your resources. Sometimes airway is not difficult, but the position is critical. And do not ignore the physiologically difficult airway. Thank you.